So there are a number of occupational exposures that may be important, and there's no firm confirmation for most of these, but it does seem like raising birds, hairdressing, people who work in beauty parlors do have some increase in the risk of developing pulmonary fibrosis. Chronic gastroesophageal reflux, acid reflux, is associated with pulmonary fibrosis. The association might be that acid getting into the esophagus or maybe spilling over into the trachea might cause damage to the lung that then can result in an ongoing fibrotic process. It could also be that people who have pulmonary fibrosis are more at risk of developing gastroesophageal reflux, because most patients with pulmonary fibrosis have some gastroesophageal reflux, if we look carefully enough. So we're not quite sure where the association is, but it seems to be real. There's some infectious agents, Epstein-Barr, that's and hepatitis C and CMV, cytomegalovirus. Those are three viral illnesses that may be important in some patients. And there's some soft evidence, I think, that antidepressant drugs could be related in some patients to pulmonary fibrosis. Oh, graphs. There are two ways of thinking about a disease: what's its incidence and what's its prevalence. Incidence is how many patients are going to get the disease over a certain time frame, and prevalence is how many patients actually have the disease at a particular point in time. Either way you look at it, both incidence and prevalence increase with age. Idiopathic pulmonary fibrosis is uncommon in people younger than the age of 45. That doesn't mean it doesn't happen, but it's uncommon, and then increases with age. And you can see that boys get this more often than the women. Most patients are over the age of 60 at the time of presentation, about 2/3. And white more often than black or Asian. How do we know it's idiopathic pulmonary fibrosis, not just one of the other fibrotic lung diseases? Well, it takes some clues to get the process started. So this could be a non-smoker, a former smoker, or a current smoker, so anyone is possible in there. And then the most common symptoms are gradual onset of shortness of breath on exertion. Isn't that a little bit like getting older? It is, and that's what makes it hard sometimes to think about who's developing this disease. It's real easy to say from the patient's side, oh, I'm just getting older. Oh, I'm not as active as I used to be. I don't do all those vigorous things that I used to. Which came first? I'm not sure. And from the doctor's point of view, oh, you're just getting older. Same arguments. Maybe this is, just you're getting older. So it is difficult for patients and doctors and family members to really know when is the right time to say, could there be something wrong here? The symptoms have usually been present for at least 12 months, more often 2 years by the time people finally say there might be something wrong, or until the doctors get it through their head to sort of test something. Lots of patients have a cough that won't go away, and it doesn't seem to get suppressed by anything. One of the real difficult parts of pulmonary fibrosis. Some patients have a particular finding in the fingers in which the shape of the nail bed is domed a little more than it should be, and you lose the angle between the skin and the nail, which is usually an angle like this, and it kind of flattens out and sometimes just curves off, and that's called crubbing. And most patients have crackles in their lungs. That is a sound that's a little bit like what you get when you pull Velcro apart, a sort of instantaneous little snapping, or a whole series of snappings that you can hear, and that crackling sound is what we associate with pulmonary fibrosis, one of the most consistent signs of the disease. How do we know it's idiopathic pulmonary fibrosis? Well, we need to see the fibrosis. So on an x-ray, you might get a picture that looks like this one over here. The black areas are the lung tissue, and the things that are more solid than the air-filled lung show up as white. So for instance, here's a rib, another rib, another rib. And when the rib turns and comes around, it's not as dense, you can't see it as well. There are not an awful lot of little lines down in the bottom of the lung and over here along the heart border, sort of spreading out into the lung. And that's what pulmonary fibrosis looks like. It looks like extra lines, random lines spread throughout the lung, more often at the base, the bottom to begin with, and then spreading farther up. This is actually an x-ray of a pretty advanced case. So some of the things that radiologists write down, x-ray speak for pulmonary fibrosis: chronic changes, prominent interstitial markings, fibrosis, honeycomb. And these certainly ought to suggest to any doctor that there's pulmonary fibrosis, but some of these also could be the precursors of frank fibrosis that just hasn't been named yet. Sometimes we go back in old reports on x-rays, radiologists have actually been mentioning those things without actually saying the word fibrosis, which would have been helpful. So this is an earlier x-ray on the same patient, and I think you can see it's not as abnormal, especially over here along the left heart border. We don't see all these markings. And if we really get up close on this, right in this area, I'm going to make that area bigger. There's a whole host of lines and little pockets, round circles that you can see. And those are the outlines of the fibrotic lung disease. The darker center in the middle is the air, and the wider areas are the fibrosis. Fortunately, we don't have to depend on plain x-rays anymore. We can get wonderfully detailed views of the lung with a CT scan, especially what they call a high-resolution CT scan. And what we're doing is cutting up the lung in very, very thin slices, about 2 millimeters thick. That's less than 1/4 of an inch. And we get a picture of that one slice of the lung. So that's what we've got, that's what I've got up here on the screen. This is the heart, the big blood vessels coming out into the lung tissue. This is the big aorta heading south down to the diaphragm. You can see ribs and spine, muscle up front. Here's the sternum. The dark area is the air-filled lung. And there are blood vessels coming out here, smaller branches. You go out to the edge, they should get smaller. And the lung tissue that's normal is this gray area where you can see little bits of sort of a lighter gray in there, or white. Those are the blood vessels in the lung. And out here at the very edge, this is the pulmonary fibrosis. These dark white areas surrounding some air in this spot. Other areas farther back here, a rather big opening here, presumably due to the fibrosis. Some along the edges here, and some up front. And this kind of detail was not available up until maybe 15 years ago. CT scanning wasn't really good to show us these details. But in the last 10 to 15 years, it's really become remarkable how much detail we can see in these high-resolution images.
Would this be a normal diagnostic tool that anybody that's starting would have this?
The normal progression here, the question is this a normal tool? Yes, it is a normal tool. It's available to all physicians. But the usual progression is, I'm short of breath, let's get an x-ray, something not quite right. Maybe they would do a breathing test, we'll come to that, or they would get a CT scan. And a good radiologist can certainly pick all these things up and share them with the practitioner. So here's a more advanced case of pulmonary fibrosis. You can see now we've got these areas of sort of cyst-like spaces where you've got very thick tissue around some little areas filled with air. So you can make a comparison then to a biopsy specimen, which is what I've got down here at the bottom on this side. Kind of hard to see our little spot. But this is the edge of the lung. This would be right up against the ribs. And you can see this is all solid tissue. This is fibrotic material. And you can see in this case the fibrotic material extends out into the lung a long way. And that's what these bands are that we can see coming off the edge of the lung. These are normal looking alveoli. Very thin wall, lots of air in between the walls of the alveoli. And you can see how much different this area of the fibrosis is. So how do we know it's IPF? Sometimes we depend on the CT scan along with the pulmonary functions is good enough. Sometimes physicians say, I really need a biopsy to find out what kind of pulmonary fibrosis it is. And so we do biopsies, but we aren't doing biopsies as often as we used to because of the great detail that we can see on CT scan. And the nice thing about the CT scan is that you can see detail from the top of the lung to the bottom of the lung. You get the whole look at the lungs. A biopsy just looks at one small little